Okay, thanks for having me again. It's good to be back. I feel so comfortable here now. I seem to come here twice a year or 3 times a year. But I guess hopefully we'll be back again. Mike and I will be back again in the spring, hopefully. I don't know. Okay, so I didn't know who the patient's going to be for today. I wanted to ask just to save time so we can just summarize the findings. But I'm like, yeah, we'll just do it tomorrow. And I didn't know it's going to be Mike. So, and I have no idea what's going on with Mike, so we will all figure out today together. You guys will help me. Okay, Mike, tell us where your pain is.
So I have pain on both sides, but mostly on the right side.
Okay. Anterior. Okay.
And it's when I'm biking.
Biking. Okay.
I don't have it right now, but I can make it hurt.
Okay. Flex the hip. So how long has it been going on?
Since I was 17.
17. Any injuries, accidents? Okay. All right. What were you doing around that time? What sports did you do?
I think I might have hurt it playing basketball. I might have hyperextended it. But
okay. Okay. Playing basketball, and then did you get any treatment for it? Any other? So it went away, or did it continue? It's still there since the age of 17. Okay, it's still there even after the fellowship. Okay. And then so biking, what else aggravates it now?
Turning it this way.
Internal rotation. Okay, what else? Sitting for long periods. Okay. Walking.
Not so much.
Not so much.
Maybe running.
Running. Okay. What makes it feel better?
If I don't extend it too much.
So you avoid those motions. Okay. Do you ride your bike regularly? Okay. How often?
5-6 times.
Oh, that's good. You do long distance?
12.
Oh, okay. 12 miles. Okay. Anything else that you do other than riding your bike? Not so much. How's driving, sleeping? Okay, that's good. So we know he injured it, hyperextending the hip, playing basketball at the age of 17. Current aggravating factors are sitting for prolonged periods, flexing the hip, riding the bike, which is a lot of hip flexion, repetitive hip flexion, and what did you say, running, hyperextending the hip. Anything else that I missed? And then what makes it feel better, avoiding those things. How bad is the pain from 0 to 10 at worst? Okay.
If I'm in those positions, I know it's painful, and I have to change it. Otherwise, it's...
Okay. How high does it get?
5.
When was the last time you had that pain?
2 days ago.
2 days ago. Okay. So it's frequent. So every time you ride your bike, you get it. Okay. How bad is the pain right now?
There's no pain right now.
There's no pain right now. How about any injuries in any other parts of your body? Back, knee, ankle? Just sore. Which part of the back? It's related to this, or you have a different injury? Probably different. Okay. We shall see. No, sure. I mean, right? Okay. So I'm thinking based on those aggravating factors, pretty consistent, I'm thinking there's probably some femoral glide, issues going on. I'm thinking anterior because it's in the front of the hip. So it's pretty consistent because when you're thinking about femoral anterior glide, those are the things that would cause anterior glide. Okay. So when I'm thinking anterior glide, I don't see it as often with. This is just just a fun fact. I don't see it as often with male patients. It's pretty common with female patients, just because women are more just flexible. Dancers. When I see dancers, ballet dancers, gymnasts, runners, yoga people. So I'm thinking if you have hip pain, I'm going to look for anterior glide or posterior glide. Okay. So let's see. Anything else that you want to know about Mike? Oh, the femoral head moving a little bit more forward. Yeah. Instead of, when you're moving the hip, it should stay in the socket. The femoral head tends to glide, to have that extra anterior motion when it's moving. Sorry? Yeah. Yeah. Because those aggravating factors are consistent with, or like patterns when you see a femoral anterior glide problem. Okay, let's go ahead and stand up, Mike. Okay. Yeah, probably better. So all my patients are shirtless, upper body, lower body problems. I take their shirts off, obviously for upper body, obviously for back. Lower body, I still want to see the spine. So my patients are either wearing shorts and don't have shirts. Okay, what's the best view? Maybe this way. So let's step forward. Okay, just stand normally, Mike. And first thing I want to look at is what the overall appearance of Mike. Other than don't move, Mike. Oh. Okay, well now that changes. That looks more even now. So I usually step back to see what's going on. And I try to fix their shorts or pants just to make sure it's not the pants or shorts that are crooked. Okay, nothing sticks out, but as I get closer, there's like a lot of tone in the paraspinals. Okay, Mike, can you pull your shorts up, or I can fold this from here so I can see the knees? Okay. Okay. All right. So with Asian patients, they usually have flat spine. It's the first thing I see. So yeah. All right. That looks good. All right. So first thing I want to look at, my hands are cold, Mike. Level of the iliac crest. Seems like you're pretty good, pretty even. I didn't see anything, so I'm just looking at the level of the iliac crest, if they're level or not. And I'm checking for ASIS, so my forefingers are in the front. Nothing sticks out to me. Nope, pretty even. If anything, the right side's probably more anterior, but just very, very slightly. Not too worried about that. Okay, so lumbar spine pretty flat from the back view. Femur, there's some medial rotation going on. Lateral view. Oh, how super flat. Okay, you've been working on it. This is better, or this is better?
It's a little bit better.
Yeah? How bad were you before? Oh, like more hunched over? Okay. Okay. This looks good. Step back more. Okay. Maybe a little sway, but not that much. So maybe let's face this way so they can see the lateral view. Okay, arms across your chest. Okay. I'm going to sandwich the pelvis anterior and posteriorly. Maybe he is slightly anterior, but not significantly. Anterior to neutral. Okay. Can you see where my hands are pointing? The plane of my hands is slightly anterior, facing more like this. To the torso. Yeah. So the plane of my hands, if it's the pelvis is neutral, my hand should be like this. Anterior tilt is this way, posterior tilt is this way. Okay. Oh, as you stand more, I can see that you're swaying more. Yeah. Okay, now he's really more anterior. And I can see there's more flexion up here. Okay, and then I'm going to bisect between my fingers, draw a line along the femur. So my two fingers should be forming a straight line. Seems like this is just slightly more posterior than the top hand, just slightly. So I'm thinking the hip is more extended. He's in slight. He was more hyperextended earlier, so his knees are extended. So the ankles would be in what position? If the knees are hyperextended, what do you think is the position? Plantar flexion, and relative plantar flexion. So I'm thinking sway back, anterior tilt, hip extension, knee hyperextension, ankles in relative plantar flexion. Yeah. So that's consistent with femoral glide, because if they stand like this, they're pushing their femoral head more forward. Yeah. Oh. No, because if the knees are further back, because you're not really in a straight line, that puts the foot more in a more downward position relative to the tibia. Okay. So let's face the TV screen. Okay, so now we may need to step back, Mike. We may need to step back. We're going to do I don't know if I want to do forward bend on you. Let's do it. Do it. Okay. So like, do I show the full exam or should I just go straight to the point? Okay. So with forward bend, I usually place my hands on the patient's hips because I can't see very well. Sometimes I can feel it better or see where what my hands are doing. So Mike, go ahead and touch your toes, bend forward, and then come up. Any pain with that? Nope. So now what I'm looking for here is when my hands start to move. The hips should move around the same time the lumbar spine is moving. Okay. So you guys tell me. Go ahead and forward flex. Kind of delayed, right? Right. So now I'm thinking he moves more readily in the lumbar spine compared to the hips. Any pain? Okay.
I have pain on the back.
Oh, doing that. Okay. There you go. So Mike, let's see if we can. It will be easier for you to do this because you know what to do. So flex from the hips first, and then in lumbar spine. How did that feel? It's better when you start from the hips, and I can feel like my hands are moving really well. Okay, and then let's go ahead and do extension. You can place your hands here, and then come up. Actually, let's face to the right this way so they can see extension. Go ahead and lean back. And then come up. How's that? Yeah. He doesn't. The spine remains straight, and then he just pushes his hips forward. So that's where he's getting the motion. Did you say you have pain in the back? Okay. How about if you don't push your hips too far forward? Do that again. How's that? It hurts your low back. In general, I don't normally do hip extension, but I wanted to see what the hips are doing in this case. We definitely don't want him to keep pushing the hip into extension or hyperextension. Okay, let's go ahead and face the screen again. Let's do rotation. Yes.
Originally, you were contemplating doing flexion.
Mm-hmm.
And it sounds like it was something optional. Is there a site that you saw that it sounds like you didn't have to do the flexion test?
Mm-hmm.
You already knew exactly where to go and jump to next.
Yeah.
Where did you see that allowed you to catch why that would have been optional? Did you skip over it?
Skipped it. Well, I forgot that he had back pain. And I want to just do other tests to confirm more my hip diagnosis, my working diagnosis. But then I remembered, oh, he has back pain. Let's do it. So how is his back affecting the hip? So let's do it anyway. Plus you told me to do it, so I did it. I did it. Okay, so where are we now? Rotation. So arms across your chest, rotate to the left and right. So right now I'm not stabilizing. I'm just seeing how far he's going and where he moves more. You have pain there. Okay, let's go to the right. Seems like a little bit more limitation going to the right this way. No pain there?
It's on both sides.
On both sides. So when you go to the left, you have pain on the left. When you go to the right, you have pain on the right. He's also bending this way when he turns to the right. So now I'm going to stabilize. So let's go ahead and turn to your left. How's that? Okay, to the right. How's that? No pain. So you can see how he was moving more here in the pelvis. When I take away the movement of the pelvis or the lumbar spine, that makes him feel better because he's rotating more up higher, which is what we want. Okay, but no hip pain.
No hip.
Okay, great. So now let's do single leg stands on the left. Okay, and then let's do it alternately on both sides. Okay. Okay, left again. So I'm just looking for torso, pelvis, what the femur is doing. Left and right, keep going. This is actually pretty good. Do left side. Do you guys see anything?
Can you turn so we have a lateral rotation?
Oh, okay. Face this way. Mm-hmm. Okay. You guys see anything that you want to point out? Standing on the left side, what is he doing? Yes, I saw that too. But the right is fine, right? Okay. Right side's fine. Okay, let's face forward. Sorry, forward that way. Okay, so now I'm just going to move on because I'm just thinking, why is he leaning to the left? Maybe I need to look at the strength of his hips. So I'm just going to keep that in my mind. Okay, so now, Mike, let's go ahead and show me how you squat. And then come up. Any pain with that? Soreness on both sides. Okay, let's do lateral view. And then come up. So guys like that. It looks okay, right? Do you feel that at the end? Yeah. And then face that way again. So tell me when you start feeling it. So the deeper you go, the more pain you get. Okay. How about if you don't go as low? He's okay. Like his mechanics are fine. I'm not gonna do anything here. I'm just thinking like, oh, the more hip flexion he gets, that's when he gets the pain. Okay. So let's go ahead and have a seat. Okay, looking at alignment here, considering we're looking at the femoral head position. Get back a little bit more. Okay, so the pockets are in the way, but typically when I'm already thinking femoral anterior glide, I can't see it because of the bunching of the shorts. Should have worn like cycling shorts so they're really fitted. So you ride your bike. I mean, dressed apart. I can't tell really, and even if I can tell, like you guys can't see it. So with femoral anterior glide, you're expecting the anterior hip would be higher or would stick out more compared to the other side because we know that's pushing more forward. Any pain here? No, but the longer you sit, the more you have pain. Okay, all right. Does it matter what chair you use?
The lower the chair.
Okay, so the more hip flexion he sits, the more painful it is. Okay, try to relax there. I'm not going to check hip flexor strength, but I'm just going to check the hip rotation strength. So go ahead and keep your foot there. Don't lift your thigh up. Keep your thigh flat. I want you to feel it here. Feel it back there, anywhere. Don't let me push you. Be strong. Painful? No, it's just hard. It's hard to do. Okay, we'll go this way. Not going. I'm going to look at that later. This moves easily.
It's painful. This is my pain.
And I'm hitting a wall and he's guarding at the end. Like I just don't want to do it again. That's how it felt like.
Check my hip flexor because I think it's going to be related.
Oh, like strength? Oh, okay. Oh, length.
Strength.
Oh, strength. Okay. Okay. Hold it here. Keep your thigh down. Keep your thigh down. Whew, quite a bit. Okay. Hold it there. You should do some bar classes too,
That's painful.
Get some hip stuff. This is painful too. Where at? That way. Okay. All right. Why do you think you want me to? Why should I check your hip flexor
I'm thinking
strength?
it's long.
Oh.
That's
Oh,
why.
you said length. Check the length or strength?
I'm thinking it's weak.
Oh, you're thinking it's weak, so you want me to test your hip flexor length or strength?
Yeah.
Okay. For length, yes. Yeah. For anterior glide, I don't go for the Thomas test because it's just gonna irritate them. And usually when I get these patients, they're pretty irritated. So the more confirmatory tests I do, the more painful they get. Yeah, but I'm more thinking of what movements of the hip cause the femur to glide anteriorly. So yeah. So I don't know if I want to do that to you. Do you think you're going to be positive?
I'm thinking maybe the strength.
Oh, good. Okay.
If
Okay.
it's weak.
Okay. Try to relax.
Okay.
I wouldn't normally do that because they're already painful, but he's not in pain, so he invited me here and he wants me to do it. I'm going to do it for him. Try to relax. Let me do it for you. Oh, let me do it for you. Hold it there. You're on your own. How does that feel?
It's It's uncomfortable. It's
Uncomfortable,
it's sore.
painful. Okay, let's not do it. Okay. Let's not do it. Would you do a posterior glide when you do that? When you get pain when you're actively holding?
Because I'm just limited in range.
Oh, okay, okay.
But usually my hip flexor would be weak.
Okay.
That's why I'm gliding.
Yeah.
But this is hurting me.
Yeah, it's an active hold. Yeah. Okay, let's go on your back, face up. Okay. And straighten your legs. How are you in this position? And you said you're okay at night?
Yeah.
Okay. So here's what I'm gonna do. I'm gonna find the femur or the groin. Just let's do it passively, Mike. I don't want you to help me. Let's just bend this so I know where your hip bends. Okay. So I'm gonna put my hand on just below the SIS, just where the crack is. Okay, where the fold is. Try to relax. And what my left thumb is doing is just feeling for what the femoral head is doing. Okay. And I'm gonna show you two options because I'm not always successful on this one because the hip flexors get in the way. Try to relax. I'm going to do it passively as far as I can, and I'm feeling for what my left thumb is feeling and doing. Okay, go ahead, and you can see how my left thumb is moving more forward. We're going to do it again. So my left thumb should just sink in and stay there, but I can feel how my left hand is doing this, a little arc of motion. Okay, try to relax, Mike. The more I flex, the more my whole hand is moving. Go ahead and hold it here, Mike. Okay, there's a little bit more pressure, not significantly, and relax. How did that feel? It hurts, but not when I was doing it passively. Okay, second way. First way, thumb anteriorly. Second way, I'm going to find a greater trochanter. Sometimes you don't feel it on top, but the greater trochanter, it's usually less, there's less soft tissue in that area. Okay, try to relax, Mike. It's actually pretty good. Hold it here. Actually, it didn't move. So now I'm not sure if what I felt there was the hip flexors or just the muscles kicking in. But here's what I'm going to do. I'm going to apply posterior glide here. Try to relax. And hold it here. How's that? It hurts. That's hard to control. A lot of hip flexors going on there. I'm just going to use the lateral border of my hand, or the pinky. Okay, try to relax. Is it tender?
No.
No, okay. It's hard to control. I can't push as hard. Okay, hold it here. How's that? Okay, all right. But I'm working too hard. I don't want to do it again. Okay. We're going to do some other test that's easier for me and for him to do it. Okay, it was really hard. I was working hard. Okay, just try to relax, Mike. I just want to check your range of motion. How's that? That hurts. You're just a little bit past 90. Okay. Let's check in the range. Try to relax here. You can clarify it. Is that your pain or, yeah. But usually when they're, relax. If they're consistently pointing out that hurts. If let's say, oh, that feels different, or is that your pain, or am I stretching you? I would ask more specifically. This is okay.
That's my pain.
That's your pain. Okay. That's very limited. Have you had any imaging? Okay. Since 17 years old. That's like, what, 40 years ago or something? I don't know. I'm not good with math. I apologize, Mike. 40 years and no imaging? This is okay. This feels easier to move. Yeah. And it has more range. Oh, relax. How's this? That one's sore. Okay, let's have you. So the next test I'm thinking of would be sideline gluteus medius strength test. You guys think I need to test it? I need to see the strength. One leg, single leg stance. So you wanna know. there was difference, right? He was leaning more on one side. So we should do it.
Yeah.
Okay, let's go line that side. So I'm very picky. We're all very picky with gluteus medius strength test. Can you just get back towards me because I'm short? Oh, this is okay. After practicing more than 10 years, Michael had to teach me how to do it right. Because I guess, for over 10 years, I was doing it wrong. And I wasn't getting accurate strength of the muscle. So go ahead and lean more forward. Move hip forward. So try to relax, Mike. So I'm just going to flex. Oh. Relax. Passively flex, abduct, and externally rotate the hips to make sure I'm getting my gluteus medius. It's hard to extend him. Flex this. Okay, hip more forward, Mike. Just the hip, not yeah. Okay. Try to relax. Okay. I got it, Mike. I got it. Give it to me. Okay, there you go. Good. How does this feel? It's okay? All right, so I can feel his gluteus medius. You got it? I'm going to let you go. You got it? Okay. And I give him time. I let them know what they're doing. And don't let me push it down. Don't let me push it down. Oh, that was easy. He's contracting, so I know he's using his muscles, but he was letting it go. Not strong enough. Let's do the other side. Okay. Just me, Mike. Just me. Don't be helpful. Okay. Hold this position. You got it? Good glute contraction. Hold it here. Be strong. I could sit on this leg. This is solid. And this is the right leg. The right leg. So maybe that's why he's leaning. He's laterally leaning to the left during single leg stance because the gluteus medius is not doing the job to keep him straight, right? Okay. Next up, prone. Lift your hips up. Oh, this under your belly. I usually put this just because it's just uncomfortable to be in prone without support. A lot of us don't do that, but I'd like to be gentle on my patients. Because I'm going to do tests that may make them sore, so I'd like to make them comfortable. Mike, if I forget anything, let me know.
Maybe the quantified over sideline.
Don't you do that? It's fine.
Or you can get the TFL.
Yeah, with prone. I don't normally check for do the overs test because I can get the TFL, get an idea of what the TFL is doing in terms of its length in prone. Yeah. All right. So in this position, I'm just looking for, let's look for if there's any TFL involvement here. So I'm going to place my hand just to monitor what's going on here. I'm going to passively flex the knee. Try to relax your Mike. Already I'm feeling some anterior tilt, some lumbar extension, and you can see that from your view. Like his butt is lifting. And that's the left side. I'm going to abduct him to give into. You guys are so quiet. You're making me nervous. Oh, it feels better. It looks better. There's less compensation. Maybe towards the end when I really stretch him, but I didn't feel it as much. Okay, so thinking TFL. All right. It's better. I can feel some extension second half of the range, but it feels better on the right. Yeah. Okay. So Mike, let's do it actively on the left. Okay. I'm seeing it second half. Right side. Okay. Towards the end, I'm feeling some lumbar extension. Any pain, Mike? Okay. So normally I would just give it as an exercise because it's pretty consistent with the hip stuff and the back symptoms or the back impairments. But for the purposes of time, I want to do the other tests because there's more important tests that we need to do. But as a home exercise program, I'll teach him how to engage the abdominals, not move the pelvis. My cue would be keep your pelvis glued on the pillow as you flex the knee. Go as far as you can without letting this part move. So we know he's just getting a pure quad stretch or knee movement without affecting the lumbar and the pelvis. Okay, so now I'm going to test for hip lateral rotation passively. I'm doing passively because I want to know how it feels first before I ask them to move. Some rotation. See my hand moving? It's moving along with the leg. Okay, same thing on the right side. I'm going to AB duck him. That feels better. I'm going fast here because I want to spend more time on the other test. That's fine. Okay, so Mike, let's do it actively. Go ahead and do hip lateral rotation. Pretty obvious, hip is moving or pelvis is moving. Let's do the other side. You can see that pretty well. Okay, no pain?
On my back.
On your back. Ah, there's pain. Let's see if you can make it better. So you do have some back stuff going on. So let's go ahead and tighten your abdominals where my fingers are. So normally I would palpate under the rib cage. There you go. And then keep this pelvis still. Don't let it move as you move your leg inwards. So that's better. He's not going very far, but at least he's not hurting his back, hopefully. Any pain in the back? No pain. And you can do it slowly. And this is a good way to stretch the TFL. And I tell them it's not a big stretch, but you're isolating the hip motion so you're not hurting the back when you're not moving the back. Okay, good. All right. So now prone hip extension. Because we're suspecting anterior glide, maybe I should move over to the right side. Oh, yeah. Yeah, the range of motion, yeah. Yep, I lost it. Okay, so I'm going to cup the greater trochanter again with my 2 fingers, and I'm going to look and feel what it's moving. So Mike, go ahead and keeping this leg straight, go ahead and lift the whole leg up. And I can feel the bone going down towards my index finger. And then let's do that again. And you can't see my fingers moving, but I can feel the pressure of the greater trochanter against my index finger. So what am I thinking? Femur is moving anteriorly. Okay. So any pain there, Mike? No pain. Okay, lost it. Okay, so Mike, this time I want you to try to engage the abdominals, just so you're more stable here. I want you to squeeze your glutes and think about, okay. Do that again. Not doing it right. He can't do it without pushing that hip forward. Okay, try to relax, Mike. Okay, tighten your abdominal muscles. Go ahead and slowly squeeze your butt. Okay, okay. It's better when he does it slowly. I don't think he's getting a good, relax. Relax. So I was wondering, like, why, if he's using the glutes, why would it cause more anterior glide? When he did it slowly, he felt better, but then as he held it, it just went down again. So, okay. Really good hamstrings. Actually, more on the left side, there's more tone. Good job, Mike. Okay.
Michael, are you thinking that it's more of like a sequencing issue as far as which muscles are firing?
Yeah. And I'm going to do the same test, but I'm going to look for activation of the glutes and the hamstrings later. Okay. So let's just see. Mike, go ahead and squeeze or think about the glutes. Think about the glutes. Okay, now slowly lift that right leg up. Okay, so now it's not moving. Now it's not moving, but it takes cueing and training Mike. And he's a PT, he knows what to do. A lot of our patients don't know how to do that. Quick info, if let's say they can't squeeze the glutes when they're not without using the hamstrings, I will do the prone foot pushes, which is like the frog leg position. So knees apart, feet together, so they're more in external rotation. That would encourage more hip activation. So let's flex your knees more. And I would ask them to, press their feet together, squeeze the butt muscles, still really strong in the hamstrings. If, let's say, they can't do it right, downgrade would be, I may support their legs here, put pillows here, a wedge, or against the wall. Some kind of support, so he's not really working hard here. So more downgraded position. And I might want to do this before they do their hip exercises, just to make sure they know how to squeeze their butt muscles without activating the hamstrings. Okay, the hip extension with knee extension test to see the firing of the glutes and the hamstrings, I would just place my hands on the hamstrings and the glutes and then just ask them to extend the hip. Oh, you're thinking, Mike. Don't think. You hesitated. And then down. Don't think, Mike. Don't think. Just do it naturally. Okay, and then down. He's engaging the glutes, but the more he does it, the more he strains or extends the hip. I can feel more this. Like this, the recruitment wise, he's getting the, I don't know if you guys can see the muscle bulk. He's squeezing both, but as he extends the hip, this one keeps firing. Okay, definitely don't want to do that. So I might want to do the prone foot pushes on him to make sure he's isolating the glutes. Because if you can't use the glutes, we can't trust that he's using the right muscles when he's doing those hip exercises. Okay? All right. Oh, hip range of motion. Okay. Just checking if it's consistent with what we found in supine. This is external. Pretty good. He had good external in supine. Internal, it just doesn't want to budge. Okay. Pretty consistent. So I'm thinking if in both positions, hip external rotation is a lot more compared to internal, I'm thinking it's probably retroverted, right? And I can do a Craig's test, but it's pretty consistent with, supine and prone. And I can do that, but do you guys know how to do Craig's test? I think we practiced that last time. Got it? Okay, good. Let's see. Hip retroversion. So when he's internally rotating the hip, it hurts. I'm wondering too when he rides his bike. Let's talk about that later. Let's do quadruped before I jump into functional state. So far, so good, you guys? Too much or just right? You guys have done this many times, right? Like all these in-services? Good to hear. Yeah, always. All right, this is more like a review, right? Like, got it. Yeah. Enter glide, positive. Okay, so Mike, can you move back a little bit so your feet are off the table? Okay, there you go. I like the feet off the table doing quadruped just so the legs are more relaxed. Legs are not flexed as far. Okay, here, this is Mike's preferred alignment. Are you thinking right now, Mike? No? Okay, because it looks good to me, right? It looks good. Spine is straight. Maybe move back a little bit. He knows how to be in quadruped. Okay, so now my hands are going to go on the greater trochanter on both sides. Okay, there we go. Interesting. The right side seems to be a little bit more posterior compared to the other side. Or left side is more anterior compared to the right side. Can't tell. So I'm going to keep my hands here, my fingers here, and I'm just feeling for what the greater trochanters are moving as he rocks back. Go ahead, Mike. Rock back. Okay. And you guys can come up if you want to see, and then come up. You guys want to see what my fingers are doing, so the best view would be right here or behind me. So I don't want to make it up. You guys tell me what you're saying. So this is the resting position of the greater trochanters. Go ahead and rock back. Can you tell the difference between my two hands? Oh, stay there. This one? Oh, this one is more anterior. So watch out how, as he rocks back, what my right hand is doing. Yeah? It's moving more forward. It's gliding more like this. Okay, yeah.
I get that early lumbar flexion. So if I fight it, this is all I really have. Unless
Then you can go more. Yeah. Okay. That's all you can flex, and does it bother you? Let go. Yeah. It's probably why you're getting some back pain because the hip can't do very well, so he's getting some of the motions in the back. Don't you play tennis too?
I haven't played it.
Okay, but you used to, right?
I just,
Okay, so you used to play. Yeah. Okay. So now because if we're thinking it's probably retroverted, we're going to move the knees apart, feet together. All right, we're gonna do it again. Let's see if that's better. Yeah, I don't feel it moving. I'm not controlling yet. Is there any pain?
It's a good sore.
It's a good sore.
I know I'm getting more movement.
Yeah, and it feels like it's just solid. It's not moving, stays in place, and he's flat. He's not flexing more. Yeah, so that's good. So this would be a good exercise for him just to get more hip mobility, because we found during supine hip flexion test that he doesn't have enough hip flexion range of motion. So this would be a good exercise for him. Let's see. Anything else that you want to? I got it? Got it? Think so? Okay, so now we're thinking, yes, femoral anterior glide. Let's go ahead and stand up. I'm not a very sporty person, but I live in an area where everyone is sporty. Everyone's on the bike, on the mat, or running. So when I see people riding their bikes, they usually turn their knees in, right? I mean, I don't know. Is that because of the seat, or is that good for, being fast, speed? Okay.
No, I haven't been using it.
Because. Oh, okay. But you do have them.
No, I don't.
Oh, okay. Okay. So the pedals are narrower?
I feel depending on the body type, pedals are narrower than the pelvis, so people will come in to look at that.
Okay, I see. And I don't know,
I haven't been turning it in. I've been working on it. Actually keeping my lumbar spine from flexing, because I tend to flex because I don't have the mobility on it.
Yeah. If you get lower, right? And do you know if your knees are together, or?
I haven't been.
Because if you're in a more adduction or internal rotation position, and we didn't do the impingement test just to confirm, if he has impingement, we don't need to, because we're already, getting positive findings in the test. So I'm thinking, with cyclists, the more they flex, that's going to cause more hip flexion. And he only has about 95 degrees of hip flexion. And it's even going to be worse if he's going to turn into adduction and internal rotation. So he's getting more and more impingement in the anterior glide every time he flexes, or the entire 12 miles, 6 days a week. So any suggestions on, I don't ride bikes, so I don't know what modifications you can do on a bike.
It's the Taliban. The spin.
You go like this.
Can you raise it from a bar higher? So you're not so
I think it's a little bit high. Anyway, so I tried like this.
Okay. I'm also thinking too, even if he's in a good position, because the more he flexes, he can't control that anterior glide in a seated position when he's riding 12 miles. But I'm thinking maybe when he rides his bike, or after riding his bike, he can do some of these exercises, especially the quad rock back, just to, get some relief in the hip. And probably too after, doing some documentation. I don't know how long your documentations are here, or ours are pretty lengthy. It takes forever to finish them. So he should be doing some of those exercises after sitting for prolonged periods. If I find that, patients, I can't get on the floor in the office, just too embarrassing. I don't want my coworkers to know what I'm doing or ask me what I'm doing. So a modification would be just, can we always use that mic? Would be just a modified quadruped.
With all the exercise you're doing, would you have you temporarily stop cycling until the sequence is
Better? That's a good question. If it's highly irritable, how much pain you get? I would
can modify it. It's actually helping getting it to keep it from gliding, because I know I'm working on hip flexors.
Okay.
So I've been working on my iliopsoas
Okay.
to protect that head from.
Okay. So you're doing some exercises?
Yeah.
Okay. We can talk about that. And then you're modifying your position so it's not as bad. Okay.
I'm stuck here.
Okay. If your feet are more neutral, facing forward. So it's better because he's retroverted to turn the feet out, so he doesn't have as much pain in the hips. But if it's I have pain no matter what. I don't know what to do. If he's not a PT and has no clue about what's going on in his body, I would say just probably not a good idea to ride your bike, or just lay off, or maybe do less mileage. But in his case, if he can do it with less pain, that's fine, and hopefully with treatment that can get better. Yeah, I don't try to, because our patient populations, they're just crazy. They need to exercise because they'll just get crazier. So just to make them less crazy, okay, let's do your, just try to find that happy medium. Okay, you can do all that, but make sure let's do all this to help you perform better with your yoga moves or whatever. So Mike, let's show them the modified quadruped. All right, so slightly bend. You're probably a little too high for you, but that's okay. Let's back up a little bit. Flex your hips and knees. So pretend you're just in a quadruped position, and you're just gonna rock back, stick your hips out, keep your back flat. So you're just gonna rock back this way, and you can turn your feet out. Okay. How does that feel? It's okay. It's okay. And it's probably if you go lower with the support, you can get deeper with the hip flexion.
Just have to make sure my lumbar spine is neutral because I tend to.
Yeah. Okay. If let's say this doesn't make them feel better, or they're not really retroverted, but they're still getting anterior glide, in this position or in quadruped, I would do a manual posterior glide. So I would just cup my hips or their hips and just push posteriorly. I'm not sure which way. Okay, bend your hips. Push your hip. Okay, so I'm just gonna apply posterior glide as they're rocking back. I usually just stand like this. And I think Adam showed this before. I don't know. I don't remember. He was here. So yeah. And then how do they do it themselves? And Susie, one of our mentors at WashU, I see her all the time doing this in between lectures. So she would do it actively. She would just go like this after sitting for a while. And I used to do this because I have the same problem. I have bilateral labral tear in the hips. That's why I'm not as active anymore. Well, I never was anyway. But so I just don't dance anymore. So yeah, so just posteriorly gliding as you're rocking back. Let's see, what else?
Chest.
For what?
It's like
Eat the chest like actively?
passive.
Passively? Oh,
Maybe
yeah.
stretch.
Because you're doing some hip flexor strengthening. So one of the things that we expect from femoral anterior glide syndrome is weakness of the hip muscles, particularly the iliopsoas and the glutes, because they're not keeping the femoral head in place. So let's show them how to do, we're good with time, right? Okay. Hip flexor strengthening. I don't do this right away because usually when they come in to see me, they're already irritated. They can't flex the hip. You don't want to keep flexing the hip, right? But let's say the acute pain is better, and they can tolerate these exercises. Why not? And like I said, several weeks later, this is when I do them. Can you guys see it? Yeah, okay. So I would do it, maybe use a towel. Can we use your sweater? Okay. Oh, you're wearing it. I'm looking for it. You're wearing it. Okay, thank you. So I would do it passively. So there's no effort from the iliopsoas. So go ahead and just passively until they can tolerate it. Okay. Don't forget the retroversion. Whatever you guys do, you want to externally rotate the hip because it's just not going to work. Okay. Passively and do it slowly. A few repetitions. Maybe after a few sessions. When it gets better, it will become more active assistive. So there's a little bit more effort from the hip flexors. And then eventually you'll be doing active. Yeah? That makes sense? Okay. Strengthening. You tackle the bike. The sitting.
I've been working on it.
Like?
The way I've been flexing from the hip.
Okay. When you're sitting. Okay. Do you have a low seat here?
It's just regular seat. Yes.
Regular seat. Okay. So I would want to avoid sitting too low so he's not flexing too much in the hip. And sometimes too, I would avoid having too high of a seat because then he's going to, if it's irritated, you don't want that femoral head. If you can't control, you don't want that head sitting more forward. Okay. So you can do the prone exercises. You definitely want to do the quadruped backward rocking. Okay. Let's see. What else? You don't run anymore, right? Okay. Yeah, they shouldn't be running when they have this, anterior glide, because you want to make sure they're strong and they can improve the position of motion in the hip joint as they're moving the hip. So, and then running is just repetitive flexion extension of the hip. Okay, let's see. Anything else that I missed, Mike? Pain sitting, running, riding the bike, internally rotating. So I think it's pretty straightforward, and which I'm glad. So it's easier to see how how the whole eval works and how what we can do for it. When you have hip pain, I always look for the glide, whether it's typically it's anterior glide. So look for that before you do any hip strengthening exercises, because you don't know what the hip joint's doing. Questions? Yeah.
So the question is, like with the upper part of the shoulder, we always have to look for a neck diagnosis.
Mm-hmm.
Have back symptoms and bilateral hip symptoms. Why would we have looked at him as a back question for lumbar spine question? So I think it is a rock back early.
Mm-hmm.
Right? Why are we not looking more at a neck, a low back diagnosis like we would at the neck?
Oh, okay. Good question. So I would definitely add, okay, I will throw the question back to you. So we do know he has femoral anterior glide. What kind of lumbar diagnosis would you give him, knowing what you saw today?
Well, based on what you guys have said, he flexes early in his rock back, especially.
And forward bending.
Yeah.
Uh huh.
So I would think that he's hanging on with his hip flexors to reduce that stability as well as lumbar.
Uh huh.
That would pull anterior.
More forward.
So that's what I would think. And then it's bilateral.
Yeah.
When I always see bilateral, I go back.
Yeah.
The extremity,
Mhm.
the outside figure.
Mhm.
That's what I'd ask this.
You definitely want to look at both, but knowing that he's a femoral anterior glide, his back pain is not as consistent, and I think if we can improve the hip problem, the back will not flex as much. In the future sessions, we want to work on improving the lumbar stability, but I feel like if we can't teach the hip how to move, then the spine will just keep flexing. Mm-hmm. The hip. And I'll add, so what lumbar diagnosis would you give? Oh, okay. Flexion. It would be flexion, because it's pretty obvious he flexes too readily. Mm-hmm. And you're thinking probably in the bike too, he's pretty flexed on the bike when he's seated. Mm-hmm. Yeah. 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 I would agree with you. I would add that in my assessment. Mm-hmm. Okay. Question?
Going along with Tony, I was sort of thinking the same thing.
Uh-huh.
And this is mostly just reading about surgeons that just recently put out a paper as far as their surgical outcomes or FAI.
Mm-hmm.
The impingement were higher than what the best conservative care, which is PT for,
Mm-hmm.
than right now. So I always thought that the bigger bang for the buck might be for the lumbar one first.
To treat the lumbar.
And then going for the next best thing based on what research is telling us that's going to be the
I think when you do my eval, you're going to have the lumbar diagnosis and femoral anyway. Right?
Yeah.
Yeah, so you're going to address everything.
Yeah. And maybe
and
next.
It overlaps anyway.
Yeah. And you can't treat the hip only. I'm not going to focus on just the hip, but knowing that, his hip is moving forward, moving better now, then maybe next session, second session, I'm going to do more lumbar tests. See like how the muscle performance of his lumbar, muscles, paraspinals or abdominals are. Mm-hmm.
So you already have all the information.
Yeah, because you definitely, when you do more hip exercises, you want to cue him, as far as what the lumbar spine is doing. Yeah, so I would do more lumbar because hey, your back is not so good. And before I progress your exercises, I might want to look into the lumbar spine more. Mm-hmm. Yeah, because I feel like if we treat the lumbar spine, let's do core exercises, let's avoid flexion, let's do a bunch of, core exercises, but the hip's still not moving very well. Hip still gliding, and that's his main problem. I'm going to go with that, because otherwise it's not going to come back. I came here for the hip, but why are you giving me core exercises? Hip still hurts. I can't still ride my bike. So I'm going to go with his main complaint. And what would help my lumbar spine? It would be the hip mobility. Just teaching him how to move precisely in the hip as he does those functional activities. Yep. Yes. I would do probably in seated. Do the same thing passively. Progress to active assistive and then active. And then you can add resistance towards the end. I don't usually get to that point. I usually just get them up on their feet and do more sport-specific stuff. But from supine, if they're really irritated, sitting and then standing. Yeah. Any other comments, Nick? Anything that I missed? Okay. Any other questions? We didn't look at the gait. I don't know if you have time.
Maybe just the hamstring. If we're addressing hamstring stretch, avoid keeping the knees too straight because it's going to tend to glide, right?
Yeah, I don't really care about hamstrings. I don't care. I don't stretch hamstrings as much. With him, I don't care. Like, I didn't check the hamstring length. I don't really care about hamstring. I just want the glutes to fire more so the hamstrings don't have to work as hard. Maybe the hamstrings are short. I don't know. Don't care. I care more about the glutes because that will control my hip flexion. Maybe eventually, like, oh, let's improve your flexibility because you're a pretty tight person, you're a cyclist or a runner or whatever. You don't really stretch. Here's your home program. That's fine, but I wouldn't prioritize that. And we actually finished the eval. Tomorrow I'll be doing a demo for my coworkers, but it will be, I think it will be a back. So hopefully I don't get confused. What's that? Oh, okay. Hopefully not, because they're pretty bad. They're pretty like, I disagree. It's like, oh, okay.